All right, everybody. I think we can probably get started. Um, Good morning. Hello. My name is Stuart Brower. I am the director of the Schusterman Library here at OU Tulsa. It is my happy privilege to welcome you all to this year's first lightning round session as a part of the OU Tulsa Research Week. Um, these sessions are presented by Scholar Squad, which is actually a group that was founded as a part of the Schusterman Library, but it's kind of grown and taken off on its own. They meet once a month to talk about all kinds of matters related to the researcher's life, and highly recommend checking them out if you ever get a chance. This is the fourth year that we've done the lightning rounds, and that's actually pretty exciting. I didn't realize that we had been going that this was had been going on quite that long, but 4 years, that's pretty impressive now. We're happy to have everybody with us. There are going to be two different lightning round sessions this year. The first one of these is the one that we're having right now, of course. And the second, I want to pull this up just to make certain I don't get the time or the date or anything wrong, is actually going to be Thursday, April the 8th, and that will be at 4 o'clock in the afternoon. And so we would also hope and welcome all of y'all to come to that as well. Alyssa posted a little reminder, the panelists, we don't actually have time to do official questions and answers, but feel free to type responses into the Q&A panel if we get any questions. The format for this is that each team, each presenter, is going to get 5 minutes and 5 PowerPoint slides to present. And Alyssa, who is our helper, is going to be advancing the slides for you. So when you're ready to move to the next slide, you just say so. I'm going to be managing the timer on this end. So as soon as you start talking, I'm going to hit the little arrow that starts that timer. And I don't have, usually I have like a cowbell or something that I can ring to get your attention. So I'm just going to unmute myself and clear my throat when it's time. When it's, I'm going to do the, which is the academician's way of letting you know that the hook is coming to take you off the stage. Okay. We have seven presentations today. The first up is the produce drop, using food as medicine in diabetes and hypertension, presented by Elizabeth Wells, Mariana Wetherill, and Mary Williams from Public Health. And Elizabeth, as I understand it, you're going to be our presenter.
Yes, I will.
Okay, we'll move to your first slide, and as soon as you start talking, I hit the timer.
Well, hello everyone. My name is Elizabeth Wells, and I am a Master of Public Health student. So my presentation today is called The Produce Drop, Using Food as Medicine in Diabetes and Hypertension. And it's going to be over a project that I've had the privilege to work on during my time as an MPH student, and it is an ongoing project. Next slide, please. So for some background information, food insecurity is the lack of consistent access to healthy and nutritious foods. And then there may be barriers that can affect an individual's ability to access these healthy foods. And this could include living in a food desert, if there are no grocery stores that could carry these foods. Transportation may be a barrier, or familiarity or cost associated with certain foods. These can all be barriers leading to food insecurity. And so this lack of nutrients can lead to a variety of problems, including higher risk for certain chronic diseases such as hypertension or diabetes. So this study aimed to identify whether barriers to healthy eating are associated with chronic disease management, and to assess the impact of fresh produce delivery on chronic disease management, dietary habits, and confidence in cooking skills. So the picture on this slide, this is an example of a produce box. with some of the fruits and vegetables that could have been delivered in the deliveries to the participants. They got a different delivery every week, so different fruits and vegetables. But just as an example. Next slide, please. So this study was a randomized control trial where patients were recruited from the OU Internal Medicine Clinic, and all of the participants lived in Medicaid eligible households and had suboptimal A1C or blood pressures. Participants were randomly assigned to one of 3 groups: an intervention group with fresh produce delivery only. There was an intervention group with fresh produce delivery plus an instructional cooking class. And actually the cooking classes originally were going to be in person so they could practice some of these cooking skills, but unfortunately COVID hit right in the middle of the study, and these had to be converted to an online format where they got videos with the instructional cooking classes. And then there was also a control group. And data was collected at baseline and then 3, 6, and 9 months into the study through participant surveys and medical chart reviews. So surveys contained questions such as dietary habits like fruit and vegetable intake, confidence in cooking skills, and food security questions. While the chart reviews contained information like A1C or blood pressure, or the number of medications taken for diabetes or hypertension from the office visit that corresponded to that time in the study. So the baseline 3, 6, and 9 months. Next slide, please. So where we're at now is the data analysis. So we've come up with a plan. So we are running descriptive statistics on baseline data. We are planning to assess the correlation between fruit and vegetable intake and cooking skill, and explore differences in means of fruit and vegetable intake, A1C, and blood pressure between baseline and 3 months to look for any changes that may have happened. So this is kind of where we're at right now. We are still also working on potentially doing these associations and more potentially through 6 and 9 months as well. And next slide, please. And so we are hypothesizing that the higher cooking skill will be associated with more fruit and vegetable intake, that the intervention groups will have a higher fruit and vegetable intake than the control group, and that the intervention groups will have a lower mean A1C and systolic blood pressure than the control groups. So, and then these are just a couple of pictures of some of our team members on the produce drop, putting together some of these produce bags and loading them up for delivery. And that is all I have. So thank you guys so much for letting me present today.
Thank you very much. I didn't have to clear my throat or anything. That's awesome. I do apologize. Apparently my 1-minute warning is going to show up reversed because of how I've got the camera set up. But if you see a pink square with the number 1 written on it either direction, just assume you have 1 minute left. Very, very, very nice. Our next presentation is Hope and Culture, Relationships and Implications for Research, Clinical and Organizational Practices by Felipe Oyarzo, Chan Hellman, and Raymond Williamson. And Mr. Oyarzo, you are ready to present whenever you want to start talking.
Yes, and thank you. Hello, everyone. My name is Felipe Oyarzo, and I work for the Hope Research Center here in Tulsa. And we recently presented this paper at the World Conference on Psychology Sciences in Washington, D.C., and it will be published in a peer-reviewed journal of science as well. Next slide, please. Okay, so basically what we wanted to know, we came together, my expertise is in culture at the macro level, and Dr. Hellman, he is an expert on the theory of hope from a psychological perspective. So we came together to study the relationships between hope and culture. And just to give you an introduction to hope, hope is very important today. Actually, the state of Oklahoma is becoming a hope-centered state. Oklahoma DHS, same thing. And then if you're familiar with the concept of resilience, hope is actually becoming a better predictor of well-being than resilience with studies like the ones we did with over 3,000 participants. I mean, pretty large samples. And then culture, the concept of culture comes from anthropology, but is actually being studied from different fields today. And just based on a previous study that we developed, if any of you is interested about knowing the connections between culture and the cognitive processes of the brain, you can Google the cultural improvement theory. Next slide, please. Okay, so the first proposal that we are sharing with academia is that hope is not culture and culture is not hope. It sounds very obvious, but sometimes in the study of both culture and hope, these concepts are mixed. And there's actually a shirt made that says, hope is the culture. No, hope is not culture. Hope is actually a cognitive skill that is situated within the mentality of a group, that is within cognitive processes and within the symbolic culture. As you can see there, anthropology has divided culture into 3 different spheres: mentality, symbolic, material, and spiritual. So hope is located in that mentality, in the thinking processes of the brain. Next slide, please. Okay, so just to share in 5 minutes, it's really hard because this is a study that took a couple of years, but I'm gonna go over the main highlights of this project. So culture and hope have an important cognitive component. Hope can influence and modify culture, and culture can impact levels of hope. We were able to demonstrate that empirically. Then, as a consequence, culture becomes a foundation for the study and development of hope theory. Something very interesting in the fields of social sciences and humanities and philosophy, the terms like epigenetics are becoming very popular. However, we were not able to connect biology with hope or biology and culture. It seems like anybody, any race, any group can develop their own culture, and also they can learn how to improve their levels of hope. So what I'm saying is that there's no scientific evidence at all that, for example, a specific race will have more hope than another. That just doesn't exist. And then also one of the findings agrees with our colleagues in Italy, in Europe, that research instruments that measure hope levels might not produce the same results if used in different cultures. Next slide, please. And finally, on my last slide, so both hope and culture can be utilized to promote individual and social well-being. That's kind of a new approach because today, due to some extreme ideologies and political views, culture is not seen as something that we can improve, but in the contrary, we are like respecting culture as it is. Hope cannot be separated from culture. And finally, we are suggesting hospitals and medical settings to build cultures of hope. Thank you very much.
Thank you very much. All right. Everyone is doing great. I like this. I like this very much. You know, people have learned when I'm emceeing something like this, it's you want to make things easy on me, like as easy as possible. This is a breeze. This is so much fun. I'm having a good time. Our third presentation today is Impact of COVID-19 on Depression Symptoms in Adolescents Seen in OU Tulsa Clinics by Anna Maria Malati, Elise Knowlton, Amy Hendricks, Michelle Condren, Will Homko, Christine Myers, and Melissa Van Kane. And I am not 100% certain. I think is Melissa, are you presenting?
Yes, I'm the one who's presenting.
I got at least that much right. So that's probably good. All right, whenever you are ready.
Okay, well, yes, I am Melissa Van Kane. I am a faculty member in the departments of pediatrics and medical informatics, and I'm going to be talking about our COVID-19 on depression symptoms of adolescents seen in OU Tulsa clinics. So as you all know, the COVID pandemic has disrupted life for both adults and children, including work and school and leisure activities. The mental health effects of the pandemic are currently being studied in a lot of areas. There are some studies in adults that show that depression symptoms as measured by the PHQ-9, which is a standard questionnaire that we give to all adolescents in our OU clinics, show that depression symptoms during COVID have been 3 times higher in adults than in pediatrics. And so we wanted to see, 3 times higher during the pandemic than before. And so we wanted to see, is this true for adolescents as well? Next slide. So our objective is to compare the prevalence of depression symptoms for pediatric patients aged 11 to 25 years old before and during the COVID-19 pandemic. We extracted data from the electronic health record for OU Tulsa pediatrics clinics in 2019 and 2020 so that we could compare the trends. We looked for all visits for patients 11 to 25 years of age. We also pulled demographic data and their PHQ-9 scores to look for depression symptoms. And then we analyzed this data using descriptive statistics. Next slide, please. So we have some preliminary results. What we saw, the difference between comparing 2019 and 2020 is there were approximately 1,000 more visits from adolescents in 2019 than there were in 2020. So we saw a significant decrease in the number of visits. However, looking at the overall demographics, the only area that had a significant difference between the 2 years was actually in the ethnicity. And there was a higher percentage of Hispanic patients seen in 2019 than 2020. But other than that, the age, the race, the gender, and other demographics we've looked at so far have not been different. If we look at this graph below, we looked at the mean PHQ-9 score by month in 2019 and 2020. The blue line represents 2019 and the red line is 2020. You can see that they're actually very, very similar. We don't see a big change between 2019 and 2020 overall, except in April, the 4th month there. And as you'll see in the next slide, that mostly has to do with the fact that there were so few visits then that few PHQ-9 scores actually kind of skewed the whole mean. Next slide. So if you look at the graph on the left, this is all of the PHQ-9 scores that we had in the system in 2019 and 2020. And you can see in on the red dots are 2020, and you could see a gap basically between the scores where the clinic was not totally shut down, but we were trying not to see very many patients, and we were not seeing a lot of adolescents, especially for healthcare maintenance visits, which is when we usually give the PHQ-9. And so the ones that were done during that period, you can see are a little higher, and that's why that data is skewed when you look at the mean per month. But it's a pretty amazing sight to see what that gap is. And then if you look at the graph on the right, we were kind of looking at the severity of depression as measured by the PHQ-9 score. So the higher the score is on the PHQ-9, the higher severity that you're considered on this depression severity scale. And this is a way that the PHQ-9 is analyzed. And one of the ways that we look at it in the other populations. So what we saw was that there was a decrease in the proportion of PHQ-9s in 2020 that had no symptoms of depression, and an increase in those that had more severe symptoms of depression. Next slide, please. So overall, one of the things we're doing is obtaining additional data. We're trying to get referrals to psychiatry, psychology, and behavioral health. We're also getting diagnoses for depression and antidepressants prescribed, as well as social work notes for safety plan and referral, because a lot of times patients are seen by social work and referred rather than referred by physicians. And then some of the issues we've encountered that we're trying to work on is how do we define when COVID starts? We can see there's a gap in when we stop seeing patients, but when do you say it's when the first case happened? Do you say it's when school stopped? When do we define that? And then not all clinics use the PHQ-9 at all visits. So we were trying to use family medicine and internal medicine as well. And we really weren't able to get data on those. And then some patients have multiple visits, and how do we analyze that in a rigorous way? And that's it. Sorry, I went a few seconds over.
Thank you very much. Okay. Well, let me see here. Now, the next up is, I've got several pieces of electronic paper on my two monitors. This is easier than it sounds, but there's a lot of management going on my end. Questionable research practices being presented by Sarah Beth Bell. And Sarah Beth, are you ready to go?
All right, so I'm Sarah Beth Bell, and I'm a social psychologist working out of the ORDSA office in research development. And today I want to talk about questionable research practices. All fields of science are going through a replication crisis right now, where classic studies, when you redo them, they just don't come out. Multiple people redo them, not coming out. In 2010, a psychologist published a study in the top journal in my field proving that ESP was real. And this seemed very weird. So psychologists thought, how did this happen? Are some of other reasonable findings not true? And yeah, all kinds of things got debunked. Next slide, please. So as you can see here, this problem, while popularly thought of as mainly affecting psychology, is affecting all fields. 88% of studies in medical journals are significant. So I guess everybody's a genius. Maybe they have ESP. But in medicine, almost 70% of people who've tried to replicate a study have failed, including over half of their own studies. Half of cancer researchers have been unable to reproduce a published result. In one replication project, only 11% of preclinical cancer studies successfully replicated. Next slide, please. But yeah, as you can see, the consequences of this are astounding since this is medicine. This happens because of questionable research practices, super common things most researchers do with their data that people don't realize messes up their data and their statistics. One of the biggest ones is harking, hypothesizing after results known. You might get weird results, but then you talk yourself into, well, that makes sense. You know, I guess that was kind of my hypothesis all along. Completely wrecks your statistics. That's a talk for another time. But also p-hacking, running way too many statistical tests and maybe something will turn out. Partial reporting, only reporting the things that so-called worked. Next slide, please. This is a picture of a really cool website I would recommend you guys go on if you're interested in this topic. It lets you play with data and try to make it significant that either Democrats or Republicans were a party responsible for increasing the economy. And it's small, but you can see on the left different variables. Are you just going to include senators? Are you going to add presidents? Different things you can control for. And here I've shown that both Democrats and Republicans successfully improved the economy. Now, in my own research, especially in grad school, I have done all of the questionable research practices. Sometimes I didn't know better, but sometimes I did. And especially when I was in graduate school, if I didn't publish a lot, I would not get a job, full stop. One of my many examples is a study on ego depletion the idea that you have less motivation when you're tired. In my study, I couldn't find any results. I felt very, very pressured to run more and more stats on my data. I mean, I had given people a lot of personality tests while they were in the lab. And finally, I made my big discovery. I determined that when impulsive people are tired, they paradoxically become more motivated. This doesn't really sound right at all. And I tried to publish it, and somebody agreed to accept it, but only if I did a replication with the right number of people, even if it didn't turn out. And honestly, I knew it wasn't going to turn out. I've been totally hypothesizing after results known. Next thing I know, I have my research assistants run 800 more people through this study. And yeah, I got nothing. And by the way, that finding about being tired and your motivation has since been debunked. Next slide, please. I do wish I could say I never did it again, but I, if I didn't publish enough, I wouldn't get an academic job. I was between a rock and a hard place. I was on the market for professor jobs. I withdrew all of my applications because we have this idea that scientists are discovering new things all the time. That's not realistic, and that's how we discover nothing at all.
Thank you very much. Okay, next up, we have the association between perceived social support and hope scores among survivors of domestic violence. Kimberly Breeden Osborne, Jody Worley, and Jennifer Kaisermore. And Kimberly, you're going to be presenting?
Yes.
Okay, whenever you're ready.
Right. Hi guys, my name is Kimberly Breeden Osborne. I'm going to talk about, like you said, the association between someone's perceived social support and hope scores. But before I do that, I'll kind of talk about the larger study. Next slide, please. So I'm a GRA for the polyvictimization study. It's funded through the Department of Justice Office for Victims of Crime. They have 5 sites across the US, and the Family Safety Center here in Tulsa is one of them. And so they are hoping, or they have been evaluating the relationship between various types of victimization and a range of emotional and physical symptoms. So they use a polyvictimization tool, which asks about various types of victimization, like I said, so childhood abuse, sexual, physical, neglect, specific incidences of domestic violence, but also system-wide victimizations like poverty, homelessness, incarceration. And so it asks them at their childhood, adulthood, and then current within the last year. And then the physical symptoms, the second part looks at, physical and emotional, looks at depression symptoms, anxiety, somatic, all of those things. A lot of PTSD related questions. And this one asked about their childhood, 18-year-old within the past year, and then current symptoms. Next slide, please. So through the larger study, I started looking at hope scores, and then Dr. Worley wanted to look at social supports. And so we used the original participants of the study, which was about a year ago, and we started collecting in the past few months telephone interviews with these individuals. We did several things, but like I said, we used the Adult Hope Scale by Snyder et al. And the perceived social support scale. And we got 26 people, which was very exciting. Next slide, please. So this is very preliminary, but we found that hope and perceived social supports are positively correlated, but that varied by the type of social support. And so I have a little typo on the next part. It should not say friends on that one, only family. So social supportive family was associated with agency hope, but not pathways hope. So agency hope, the motivation and the belief that you can meet your goals, but not the pathways hope, the actual ability to know how to meet your goals. And then friends, if they had high support of friends or perceived high support of friends, they had higher on average HOPE scores, both pathways and agency. Next slide, please. So limitations, it's a very small sample size, and like I said, 26 people, and it's limited to people seeking services in Tulsa. And also it's just correlational, so we can't determine the causal relationship between the variables. And something I found too, so the implications for practice, something I found was in the literature currently, we have a lot of research being conducted about HOPE scores of children of individuals who have been in intimate partner violent situations, but not about the survivors themselves. So we need more research about that. And then among survivors of intimate partner violence, if it is the case that social supports contribute to higher HOPE scores, then clinicians working with this population, we want to assess for their social supports and then intervene by helping them identify or helping them to develop some more social supports. So like I said, we're hoping to expand this and do lots more follow-up interviews to make sure this continues. We continue seeing it as we get a larger sample size, but that is it. Thank you.
Thank you very much. All right, our next presentation, Swabum, a protocol for MRSA nasal swabbing to reduce vancomycin use, by Joshua Gentes and Tashreeq Rahman. And Joshua, you're going to be presenting?
Mm-hmm.
All right, whenever you're ready.
Hi, everyone. I'm Josh Gentes. I teach emergency medicine for the University of Oklahoma. And at our hospital, I'm the chairman of the Antibiotic Stewardship Committee. Tashreeq is a pharmacy resident, and he built a protocol for methicillin-resistant Staph aureus nasal swabbing at our shop. So let's talk about it. Next slide, please. So don't try to read this slide because you'll get a headache, but do try to find online resources that can teach you about cognitive biases if you don't know much about them yet. It's kind of painful but necessary learning for folks that are interested in science and research. So I work at a burn center, and that makes us nervous about MRSA there, since some variants are aggressive pathogens of the skin. That's problematic when you have, a 20% total body surface area skin graft. And a bad outcome from a burn that's caused by an infection from MRSA can lead us toward an information bias that's called the frequency illusion. We think MRSA happens more than it does, so most people who come to our hospital that with an infection end up getting vancomycin. The result of this is that with kind of broadly equal MRSA culture percentages to the other hospitals in our system, we end up using twice as much vancomycin as they do. That's a bad number. And something else that's bad in a burn center is vancomycin-resistant Enterococcus. Also, vancomycin can be bad for your kidneys and bad for your hearing, but at least it makes your mast cells degranulate and causes red man syndrome. So clearly we had to get something done. Next slide, please. So the first thing you kind of want to do whenever you're doing this kind of thing is look up some research. So we did, and pretty much the bottom line of all these articles is that MRSA nasal swabbing can help you with vancomycin initiation or termination. Swabbing for MRSA led to vancomycin de-escalation without morbidity. A positive MRSA swab in a study from 2018 was the only independent risk factor for MRSA infection. And at levels of MRSA that are typical for most large hospitals, a negative swab has a 95% negative predictive value for MRSA. Now, there are some caveats to this. MRSA screens for therapy decisions, we avoid those in patients with recent nasal decolonization. We avoid these if people have had an MRSA infection within 30 days before admission. If they have structural lung disease like cystic fibrosis or bronchiectasis, the screens may be discordant from actual results because colonization occurs more frequently in the lower respiratory tract in those patients and should be avoided. So we don't do that kind of testing there. And in critically ill, like intensive care unit patients, we're more cautious about de-escalation, and we usually don't de-escalate till about 48 hours because 98% of positive blood cultures for staff occur within that time. Next slide, please. So when you're designing something like this, you want to think about what you want to do, and you want to use a SMART way to design your objectives. And so I like SMART. It's a good acronym for this. You want to have specific things that you're trying to do, and what we're trying to do is do nasal swabs for MRSA and pneumonia and suspected bacteremia. You want to be able to measure your outcomes. So we wanted to measure the number of swabs and the number of VANC therapy days per patient. Achievable, you have to change policy at a hospital to get this done. So we did policy change through the Pharmacy and Therapeutics Committee and the Antibiotic Stewardship Committee. Realistically, you need to have behavior change by providers. They have to actually order the swabs and then de-escalate VANC. So you have to have buy-in from them. And timely, you should expect an intervention like this to take 6 to 12 months before you really move the needle very much. Next slide, please. So how did we do? Well, the kind of numbers we're seeing, swab compliance went up a lot after we implemented the protocol. That change was statistically significant. I can show a trend toward improvement when we look at average length of vancomycin therapy, but that trend is not statistically significant yet. We do have a second tranche of data that we just released, but I'm not ready to talk about it yet. I don't have it done, but so far I'm encouraged. I do expect this intervention will show measurable improvement in vancomycin use at our shop. And I thank you all for attending.
Thank you very much. Our last presentation for today is Correlates of Employee Engagement, a meta-analysis by Shannon Terry, Jennifer Kaisamore, and Amy Morissette. Shannon, I believe you're presenting.
Yes. Hello, I'm Shannon. I'm an MSW student and a graduate assistant for Dr. Kaisamore of the Organizational Dynamics program in the psychology department. And we're working with Amy Morissette, who is a graduate of the Organizational Leadership program here at OU. So next slide, please. So employee engagement is a construct that is explored through research, and it looks at the extent to which employees are dedicated to and absorbed in their work. So this construct has benefits for both organizations and employees. Employees see, greater work-life balance. They have more passion for what they're doing. And then organizations have higher productivity, lower turnover rates, and et cetera. So next slide, please. So we're looking at what organizational factors help to predict how engaged employees are on the job. So there's a slew of research on the antecedents of engagement. So we're synthesizing that research through a series of 5 meta-analyses, a total of 196 studies. So for each meta-analysis, we'll find an effect size for the relationship of employee engagement with the specific factor we're looking at. And we'll also find a level of, so each study will have an effect size, and then each meta-analysis will have an average effect size. And there will be a level of variability for each meta-analysis. So if a meta-analysis has a high level of variability, we will then go in and look to see what characteristics of the sample and or organization might account for those differences. So next slide. So these are the predictors we're looking at. So each of the predictors will be compared with, or will be studied against employee engagement, which will then create those effect sizes. And these are the characteristics we're looking at as potential moderators for any variability in the data. So you can see the characteristics for the sample, as well as the characteristics for the organization. So country, sector, type, age, tenure, things like that. Next slide. So this contributes to literature because we're building upon the current understanding of the factors associated with employee engagement. So we're hoping to determine which conditions may support or undermine engagement. And then for any variability, obviously, we're looking to see what characteristics might explain those differences in the data. So previous research has mostly just looked at job resources, stressors, and personality factors. So this will be new in that we're looking at the actual organizational factors that might be correlating with employee engagement. And that's all I have. Thank you.
Well, thank you. And thanks to all of our presenters today. This has been fantastic. I love hearing about all the different things that are going on around OU Tulsa and all of all the fingers we have out there in all the various areas of research. And this is just wonderful to hear about. So thank you all very much for participating today.